Welcome to A Journey to Whole Woman Health, the podcast where science, mental health, and faith come together to educate, empower, and encourage women in every season of life. We are your hosts, Dr. Jamie Erwin, board-certified OBGYN,
and Dr. Mary Kathryn Nader, licensed professional counselor with a PhD in counselor education and supervision. Jamie and I have been friends for over 30 years.
Each week, we explore the intersection of body, mind, and soul, bringing you evidence-based medicine, meaningful conversations about mental health, and stories that remind us we're not alone on the journey.
So take a deep breath, settle in, and let's begin the journey. Welcome back. We are so excited that you're joining us today. We are going to talk about a very important topic today, and that is libido.
Sex, baby.
Woohoo! We are so excited. We're here to talk about some of the major topics. Have you ever thought, what happened to me? You love your partner, your life is full, but your desire is just gone. And then comes the guilt, the confusion, maybe even the shame. But what if I told you this isn't just in your head, and it's not something you just push through? Today, we're going to talk about libido and all the things, the science behind testosterone, mental health, what actually works, because you deserve to feel connected, not just to your partner, but to yourself.
Let's
do it, Jamie. We're here.
Talk about sex, baby.
All right, so let's get started. What is libido?
So libido is very complicated. It is desire, but there's a biological aspect, there's a psychological aspect, and a relational aspect. So really think of it as this kind of triangle that is so complicated. And I say that women's libido is like a Pandora's box in a way. And I don't take care of men because I'm an OBGYN, but I feel like our sexual health, our desire, our libido is just more complicated than men. I said what I said.
Yeah. I always, when clients come to me talking about this, I always say, you know, we're so different. Like our sex organ is our brain.
Yep.
And guys is their penis.
The penis.
So it's so different. For us, it's like spaghetti. Everything touches each other. If Johnny came home and had a bad day at school and there's laundry that's piling up, and it's hard for us to focus. Whereas for men, they're more like waffles. It's in this box, and I'm here for my sex time. So it doesn't matter what else is happening. I'm in this box.
And they're ready for it anytime.
They're ready for it.
I mean, anytime. There is go time.
Yes.
And we've talked about the invisible load that we carry as women. There's beautiful art that's been created. There's a beautiful statue that I've seen of just this woman and all the things piled up high into the air that she's carrying around on her back. But it's the doctor's appointments. It's, the kids need new shoes and new clothes. And did I schedule that dentist appointment? What about my deadlines at work? When am I going to work out? How much protein have I eaten? How much water have I drunk? Have I even gone to the bathroom?
Yes.
We carry that invisible load. And so how does our libido and our desire fit into that?
Yes.
It's part of our makeup. So low libido is only a problem if it bothers you, though. I think that's really important to take note of.
Yes.
So something I want to speak about is what's called hypoactive sexual desire disorder. And it's a persistent lack of desire that causes distress.
Okay.
That is the differentiator there.
And distress would mean
For
that
you.
might be different for everybody, what that would look like.
Right. Meaning you wish it were different. Okay. So I have ladies, maybe they're widowed or maybe they're single and they've been single their whole life. Great. And they don't have a desire. They have no interest in having sex. And my follow-up question when they tell me that is, are you bothered by this? And if they say no, then we're done.
Then we're done. Great.
That's okay.
Yeah.
So everybody's sex drive is different. And so to know, is this a problem or not, I would say, are you bothered by it? Or, I think this is important, is your relationship bothered by it?
Yes. Is it affecting your relationship?
Is it affecting your relationship? So
and this is so common. I feel like we need to say that because you and I hear it because of what we do, but these ladies are telling me they don't talk to other people about it.
No.
Maybe they're embarrassed or they think something's really wrong with them.
Yeah.
So I think just saying it out there, this is so normal. And it is okay to talk about it.
In all ages.
Yes.
I have ladies in their 20s, 30s, 40s, 50s, 60s, and beyond.
Mm-hmm.
And I don't want anyone to think that, it's normal for desire to just go away when you're postmenopause or perimenopause. Like, oh, well, that's just normal aging. I'm so tired of hearing my patients come to me and another provider has told them that is just a normal part of aging. Okay, but it bothers me. So
Right.
it's not normal. And what can we do about
Right.
it? That's what we're talking about today.
Great.
So let's break it down. You want to talk about the science?
Sure. Go ahead.
The science of desire really falls into 3 buckets. So let's start with the brain. And you can speak to this as well
Sure.
because, you mentioned it. You said it so eloquently. Women's sex organ is the brain. We're going to talk about the clitoris. We're going to talk about the G-spot, but our brain. So there are certain chemicals like dopamine. We've talked about dopamine. Really, that's that reward hormone.
Yes.
Ooh, that feels good. So you get a dopamine hit, right?
Mm-hmm.
I mean, this is also what's happening when you are gambling and you play a slot machine
Right.
and you put your money in, and then finally you get that ding, 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 ding. That's a dopamine hit. And that's what makes you come back and keep feeding your money to the slot machine. Serotonin, we've talked about in the past episodes as well. That's also everything is fine.
Yes.
I'm happy. Your worries are at ease.
Mm-hmm.
Cortisol, that's our stress hormone.
This can be a big factor.
Big factor when it's elevated. Cortisol also affects our insulin resistance. There are so many effects that cortisol has. Some can be good when we need to be in that fight or flight or freeze. Our cortisol is helpful, but chronic elevated stress hormone release, not helpful.
Not helpful.
Starts affecting our brain. Hormones. So, of course, estrogen. It's a dominant hormone for women. This is so, so, so important for the vulva and the vagina. So, yes, our brain is our sex organ, but when we're talking anatomy, the clitoris is that bundle of nerves right above the urethra. And I'm going to reference Dr. Rachel Rubin a lot today. She is an amazing, world-renowned expert on sexual health and function. She's a urologist. She has been on many podcasts, including our favorite, the Mel Robbins podcast. And I love how she teaches that the male and female anatomy really is similar
Yes.
when we're developing as embryos. And so the clitoris is really the female equivalent of the man's penis. And so that's where all the sensation is in that clitoris. But did you know this? That the clitoris is more than just that kind of little bitty piece that we see externally. It actually is a horseshoe-shaped kind of inverted V, and the organ itself of the clitoris extends down into the labia majora on either side. Right? So it's important that we know our anatomy.
Yeah. Which I think a lot of women don't.
They don't.
They really don't. Some don't even know the terms for all of the parts.
That's right. So that's what we're here for.
Education.
So that is your clitoris. The vulva is really everything externally. So the labia majora are the big lips or the wings. The vagina itself, you can't see. It's the inside part. So it's that internal canal. The G-spot.
Let's talk about it.
What is it? So there's actually a collection of nerves on the anterior wall of the vagina. So think, bladder and then vagina and then the rectum. If you are looking kind of at the anatomy with the woman in the supine position. So if she's laying down on my exam table, feet are in the stirrups. We talk about the 3 holes, right? We've got the urethra on top that connects to the bladder.
And some women don't realize that they have 3 holes. Yes.
You have 3 holes.
We have 3 holes,
I have
ladies.
a family member who was much older than she should have been, realizing she has 3 holes.
Yes.
But that's what we're
3
here
holes,
for, ladies.
yes.
We are here. So share this with a friend who needs an anatomy lesson. So the urethra connects to the bladder. The clitoris is right above that. And then there's this little kind of area called the clitoral hood that protects and kind of folds over the clitoris. And it's important to know that because sometimes there can be little adhesions. Dr. Rubin talks about these little clitoral adhesions that can exist, causing pain. And let me tell you, pain is a huge part sometimes of why women have low libido. Because if it hurts,
you don't want to do it. Your brain says stop.
Don't touch me. Don't touch me. So taking care of your parts, recognizing if everything's working as it should. Then we have the vagina. I mentioned that's the internal part. That's the canal. And then the last hole in the bottom, that's the anus. Yeah. So important to know your anatomy for sure. So estrogen is important to keep the vulva, the vagina, the urethra, the bladder. It's so important. And there are things in our lifetime, in our different seasons while we're on our journey, that can decrease our estrogen levels. For instance, birth control pills suppress our own estrogen, but we are taking estrogen in that pill. It also decreases testosterone. Yeah. So birth control pills increase what's called the sex hormone binding globulin, and that's kind of like Pac-Man and goes around kind of taking up the free testosterone, leaving us with less free testosterone circulating. Okay. So testosterone is really our next hormone. I mentioned estrogen for the vaginal health, keeping things lubricated, not having vaginal dryness. So, and then of course testosterone can also be lowered. But did you know that postpartum, we have lower estrogen levels as well?
Really?
Yes.
So after having the baby?
Yes.
Okay.
If you're breastfeeding specifically, estrogen is suppressed by that milk hormone spiking every time you breastfeed. And so that lowers estrogen, and that can cause a lot of vaginal dryness postpartum. In fact, it feels like a little mini menopause.
Yeah, that makes sense.
Lovely, right? And then, of course, menopause, perimenopause, menopause, estrogen levels are lower, testosterone levels are lower as well. And this can definitely cause issues with desire. It can cause issues with pain in the female genitalia, and it's important to know.
Yeah.
So this is a big part of the science of desire. And then context, so relationships, the dynamics, the fatigue, the resentment, the emotional safety in these relationships with our significant other. Desire doesn't live in isolation. It lives in your nervous system. So these hormones, the relationship, our emotional safety, it's all related to libido.
Yes. And we've talked about this, Jamie, you and I, but just with talking about how we help our patients, but recognizing that for women, we feel connected, and then that leads us to want to connect by having sex. For guys, a lot of times they have sex in order to feel connected. So it's this rigged system because we often aren't communicating what we need, and they are feeling frustrated because we're not wanting to have sex, but we're not wanting to have sex because we aren't feeling connected.
Yeah, exactly. And we've got to figure out how to break that loop because, you know,
speak up for what you need and what you're looking for.
That's
and
right.
Listen to your partner and what your partner needs.
Yes.
Yeah.
You know, being vocal about what you need, I think for me has been such a part of my personal growth story. Not being afraid to speak up.
In all areas of life.
In all areas.
Yes.
No one can read your mind.
Modeling that, yes.
And that is true for our sexual health.
And I think for women, a lot of times what they need is a nap. I mean, like their brain is so tired that they are just having a hard time, or the cortisol, the stress hormones, anything that their partner can do to help take care of or manage anything, and allowing your partner to do that is huge, because I know for a lot of women, they don't want to step back, and it's hard. It can be hard to do that. So recognizing that you need to speak up for what you need and what's helpful, and then for partners to say, hey, I'm going to help with this or that, or you really need to go take a nap. Go take some time to yourself.
So important. Let's spend some more time there on the mental health aspect of desire.
Sure.
There's even, you know, some medications that we sometimes take for depression that can
SSRIs can definitely affect. We've seen that with our patients before. So that's just something to talk through with them. That's a possibility. Not everyone experiences that, but some people do.
Yeah. So those medications like like SSRIs, which would be your Lexapro, your Celexa, Paxil, Prozac, all very good medications. Yes. And just as though you were deficient in vitamin D, we would recommend you need to take a vitamin D supplement. Yes. At points in our life, whatever may be the trigger, there can be deficiencies of serotonin where that medication can be helpful. But it is important to realize that decreased libido, less ability to orgasm can be a side effect of some of these medications, right. But not in everybody.
Right. That's true.
Yeah. What do you think about telling women to schedule sex? Let's talk about that.
I think that there is a misconception that sex should always be spontaneous, or it should always, and I always tell my clients, especially after you have kids, because it does change, especially if you're breastfeeding or your life is just difficult, and there's a lot happening. And I think that it's helpful to just recognize that scheduling can be what needs to happen. And it doesn't mean it's any less special. It doesn't mean it's any different, but it can be helpful.
I agree. And going back to our sex organ is our brain.
Yes.
In order for us to have more interest, right? So there are models about sexual desire, and it starts with interest, which leads to arousal, which leads to orgasm, which leads to plateau, which leads to then resolution. And that has been well studied in the sexual health science world by scientists. But just like when we talked about grief, how sometimes it's not always linear.
Right.
The sexual drive and sexual function and libido, it's like a circle, and sometimes you just have to jump on it.
Yes. Yeah. Well, and I think too, we talked about earlier, but men's are more like microwave and women are an oven. We need time to warm up. So sometimes scheduling it can help us to warm up. I remember, so I took a class in grad school on sexual health and counseling, and the professor said something about who came in here wanting a piece of chocolate. It was after lunch. And, of course, I raised my hand because I always want a piece of chocolate. And then he said, who, if I pulled out this tray of chocolates, would want a piece of chocolate? And then, pretty much everyone raises their hand. So he said it's similar to this in sex. Just because you didn't think of it, you're not being spontaneous and just wanting, doesn't mean that you still won't enjoy it or appreciate it.
But our culture and our society and the media, you turn on any movie, right? And it's like this hot and heavy, steamy, ripping off the clothes, can't get enough of each other. They go from dinner to just boom, right? They're having sex, and it's just
unrealistic.
So if that's what we're seeing, though, and feel like, okay, well, is that then what's normal out there?
Right.
Are other couples doing that?
Right.
Is there something wrong with us if that's not our story? But it's definitely not our story over at our house because,
there's
kids
life happening
and dogs, and I'm tired and I'm gassy and don't touch me and.
But it's true. There's so many other factors that are going on, and I think normalizing that for women, because a lot of times I do have clients even say, I don't know if this is normal. I don't know what's wrong and with me because I'm not living up to this standard that I'm seeing. And that's again, it's not possible.
It's because you've created this standard that doesn't have to exist.
That's right.
So scheduling sex, what that can look like is, okay, you know what? It doesn't even have to be like a Friday night.
No.
Is there like a lunchtime?
A lunchtime or a morning time. I tell patients all the time that, when your kids are in school or, your schedule changes, a lot of times, or even when you have a new mom, you're exhausted by the end of the day. So scheduling a time during the day, if that's possible, is great. It doesn't make it any less special.
But you're already doing that first step of having interest. So if you have it on the calendar, you are thinking about it, your brain is already going there to kind of imagine and fantasize possibly. That's okay to do. Maybe you're going to shave your legs. And you haven't done that. And you haven't done that in maybe a few days or weeks or I don't know. And maybe you're going to change your workouts up. So you're not going to run your long run 10 miles because guess what? You're not going to feel like anything after that. So you're setting yourself up.
Kind of planning it more.
Rearranging your day and your schedule, but it's getting your thoughts tuned in to think about sex because as women, we're just not thinking
we don't automatically have that thought. And I think too, I've told women before, like putting it on your to-do list, which sounds demeaning, but it's not. It's literally like prioritizing it, like saying, this is something I need to do and I want to do. Yeah. And I for myself and for my partner, and just making it a priority. And maybe, some people hear that and think, oh, that's makes it less special, but it doesn't. I mean, because we need this time to plan and think about it, it can be helpful.
It only makes it less special if you associate that emotion to it.
Right.
Like you're in charge of
you're in charge
creating,
of how you feel about it.
Yeah. So it's not demeaning. It's only demeaning if you associate that emotion with it. So you have control over that. So planning is, I think, a really great tool for ladies everywhere.
Yes.
Putting it on the calendar, being intentional, shaving the legs, changing the workout up, being sure when I am fed well and hydrated and I have had a good night's sleep, guess what? I'm going to be more open to whatever may happen.
Yes, that's right.
Yeah. So jumping into that, like, I also say that, like, sometimes you just got to go for it.
Right.
And then you may be surprised by the desire that comes along, just like the tray of chocolates.
Yes, it's so true.
And I don't want women to hear that, though, and think I'm saying, oh, well, fake it till you make it. That is not what we're saying.
No.
It's that you got to just give a little.
Be curious.
Like, be curious.
Like, let's see what happens. Don't just assume, I wasn't thinking about it, so I don't want to do this. Yeah. But you could also say, let's see how this goes.
Yeah, maybe it's great.
Yeah.
Maybe it is. And more times than not, it probably will be great.
Sure.
And then it's like, oh, that didn't take that long.
Yeah.
That didn't take that long. We can still get a good night's sleep.
Move it on with the day.
Yeah, exactly. Exactly. Oh, goodness. Okay. I don't know if my husband's going to listen to this episode or not, but he'll agree with every single thing.
I think our kids are going to love this episode.
Yeah.
Yeah. But yeah, I think it's really an important topic because it is so prevalent. It's just so common.
It is.
And people aren't talking about it. So the more we can talk about. So what are some things, if we're experiencing this, besides what we've talked about, what are some things we can do?
Okay, good. So I mentioned the pain, vaginal pain, pain with sex, dryness, anything that hurts, you're not going to want to do.
Right, and stop.
And you should stop.
I think that stop, because I have had to process through trauma with people, and this is important because you are building that connection in your brain when you continue. So if you are having pain, something is wrong, stop.
And call your OBGYN.
Yes.
And
yes, because I cannot do an exam down there. I can just tell you to go see your OB-GYN.
Yes, who will and should do an exam. And look for things that can cause pain. So there are a lot of different things that need to be evaluated in regards to the vulva and the vagina and the clitoris and the bladder.
And sometimes there's pelvic floor therapy that can be really helpful.
Yes. So sometimes imaging with a pelvic sonogram. Is there an enlarged ovary? Is there a cyst? But yes, pelvic floor is a big part if you're postpartum or not, right? There can be pelvic floor dysfunction even if you've never had children. So,
but I think that's important to empower. Hey, it's not helpful for you, and it's not helpful for your future sex life or your partner for you to push through it if it's painful. It's not going to be a good idea long term.
Exactly. So ruling out anatomical or physiological causes, or correcting those that cause pain. We don't want there to be pain with sex. But when it comes to the desire, I do want to talk about testosterone therapy. So let's spend some time talking about what the science says. And really, this is going to be for my perimenopausal and menopausal patients, that we know in those years, the testosterone levels are declining. And testosterone is made by the ovaries as well as by the adrenal glands, which are these small pyramid-shaped glands that sit on top of the kidneys we use the word renal. So adrenal. It means right there on the renal glands. So that is where our testosterone comes from. And testosterone naturally decreases with age. But there's good evidence that supplementing testosterone does improve sexual desire, does improve arousal, and does improve satisfaction, especially in the postmenopausal population.
Okay.
Now, I want to preface all of this by saying we need more data.
Research. We need more
research. But what I can share with you is, I'm going to nerd out a little bit. My scientist hat is coming on. And I just want to share with you about the research that we do have that is reliable. There was a large meta-analysis, meaning they looked at a lot of different studies. It included 36 randomized controlled trials. Those are the best, with over 8,000 participants, and found that testosterone significantly increased satisfying sexual event frequency, sexual desire, arousal, orgasm, pleasure, and responsiveness while reducing sexual concerns and distress. And this was in postmenopausal women.
But what country was this done in?
This was not in North America. And there was a systematic review of 7 randomized control trials that looked at 3,000 women using a 300 microgram testosterone patch.
Oh, wow.
Now, we don't have that.
We don't, which is frustrating.
We don't have that. In fact, we don't have any FDA-approved
testosterone
we have FDA-approved testosterone for men.
But not for women.
But not an FDA-approved formulation in the dosage that's recommended for women. So what this study looked at...
Why is that? Do we know?
Well, the patriarchy, Mary Kathryn.
Okay.
That's the short answer. That's the short answer.
Yeah.
I mean, look at it. We've got
crazy.
Viagra. We've got Cialis.
What's happening?
Yeah.
I mean, literally,
Yes.
I think I heard, was it Rachel Rubin say something like, if a man's penis dried up and fell off, there would be so many. But like for women, we don't have that. And that's essentially what's happening.
That's what's happened
to us.
Yes.
It's crazy.
Yeah. So we're changing that.
Okay.
And I'm so proud of us because you and I are talking about it right now. And we're spreading the word that, it's a problem if libido is affecting you, if you're distressed by it, if you want it to be better, if you want more desire, speak up. And we need this, and we need to lobby, and we need to have more data and more research and more funding for women's health, and specifically menopausal care and libido and sexual function. So what we do have is an FDA-approved formulation of testosterone. Now, and I do prescribe it, but what the study has been shown, so there was a 300 microgram patch, I believe in Australia, and then there was a European study that looked at a 5 milligram gel that was put on women, and so we can do this, okay? We can take the men's formulation, comes in a packet or a little tube, and a man would use the entire contents of that packet of gel or that tube of gel or cream in a day. So they would squeeze out the entire contents, slather it on. What we have to do as women to get that 5 milligrams is to use half a cc of this gel. So one packet is going to last a woman 10 days. It's 10 days worth of the recommended dose of testosterone.
So they've got to kind of
yeah, you got to kind of wing it a bit. Sometimes, always I'll encourage them to ask the pharmacist for an empty 5 cc syringe to kind of suck up and draw up all of the contents of the gel, and then squeeze out half a cc and rub that on the lower leg, alternating legs each day. It can cause increased hair growth. Yeah,
you're gonna have a hair patch.
Yep. So you may have a little hairy patch, but probably you're shaving, and if you're having sex, you're shaving your legs. Maybe or maybe not. Yeah. You know what? I just think our partners, they don't care.
They don't. They
right?
really don't.
They actually don't care. They'll take us with hairy legs and everything.
Yeah,
they just
fine.
don't. Yeah, that's them. So they love us regardless. But yeah, so 5 milligrams transdermal. It is safer that way. What's not recommended at this time by the Menopause Society and ACOG is the use of testosterone pellets or oral formulations of testosterone.
Okay.
And there's different reasons for that. The pellets in particular, you do run the risk of getting very, very high levels of testosterone, super therapeutic levels. And when levels are too high, there can be irreversible changes that occur.
Really?
Like masculinization,
Okay.
deepening of the voice. That's not going to go back to normal if you have very high levels for too long. So acne can be another side effect of super high levels of testosterone. And then with the oral formulation of testosterone, not recommended because it can really affect the cholesterol and the lipids. So the transdermal seems to be the safest. What we don't have is long-term data. We don't have long-term data on perimenopause populations. We don't have long-term safety data of testosterone in women. So we need that. But what we do know is the data is there that testosterone does help. With libido, with arousal, with orgasm, with more pleasure.
Yeah.
So do have this conversation with your OBGYN.
Yes, for sure. Is this a good place for us to stop? Because I know we were going to do a second part to this. What do you think?
Well, I think just a few more things, and we can probably wrap it up. I'll just briefly mention, there are some other prescription medications that have come out that you may have heard of. So the pink pill is called Addyi. I don't prescribe this a lot. That's my own personal choice because it is daily dosing. It works by affecting the serotonin and dopamine pathways, so that reward pathway. And one negative side effect is it can lower the blood pressure.
Oh, wow.
And it's expensive.
Okay.
And then Vyleesi is an injectable on demand, but again, it's really expensive. And it's supposed to be more like that Viagra or Cialis, like you take it when you know sex is going to happen.
Okay, yeah.
So still a lot to be learned about medications, and really we need more funding, we need more studies, we need more data.
And I think the thing too is it doesn't just affect women, it affects your relationship, it affects your partner, it affects everyone. So the research isn't just for women, it's for the whole relationship.
It is.
And divorce rates definitely go up in perimenopause. So
they do.
There's a question about how much is affected by libido.
I think there likely is a correlation.
Right.
Probably not a causation. Of course, that can't be the only factor leading to increased divorce rates, but it is true. They're both happening at the same time. So, think of the relationships that can be improved if women can boost their libido.
Yeah.
But we're not saying that this all falls on you.
No.
This is not your fault.
No.
This is the responsibility does not completely land in your corner to make this better, make this right.
This is to empower you to say, here's what's happening, here's why, and here are some things that if you choose or if it's bothering you, some things that you can do. And we can talk more about it in the next episode. Do you want to?
Yeah.
Or you want to stop here? Okay.
I think we can edit this part.
Yeah.
Bree, if you're listening, we'll need you to edit this part just a little bit. So a final takeaway, practical framework, because we know you listeners really do want key takeaways, how to integrate this into your life. Think about the 5 pillars of desire. Number 1, sleep is important. We're going to have more desire if we are well rested. So prioritize that sleep.
And this is huge. Everybody around this person needs to help to prioritize that. Yeah.
Yes. And I would love to do a whole episode on sleep.
Yes.
How do we get better sleep? Number 2, stress regulation. Again, we're going to talk about that in future episodes. How do we manage our stress? When we can really dial down our nervous system and have a better handle on our stress, we're going to have more desire. Number 3, we've talked about the hormonal support. Testosterone therapy may be for you. Using estrogen in your vagina may be for you if you're perimenopausal, menopausal, and having some vaginal dryness. Next is emotional connection. This is where that relationship, really talking to your partner. Hey, I need you to take the trash out.
Yes.
I need everything around me to feel like it's a safe place. If you want to connect with me, I got to let my brain know that it's okay.
Yeah, and this is where that old adage, like, sex starts in the kitchen comes from. I mean, it literally starts with, hey, like, doing the dishes, helping take out the trash, helping with dinner. Like, the practical things. I once saw this hilarious book, and it was called Porn for Women. Have you seen this book? And it was like a guy like vacuuming with like a smile, or like feeding the baby and saying, "Hey, hun, you go out with your friends. I got this tonight."
It's
like
so true,
it's
though.
so true. That is like what is a turn on for women.
It is.
Feeling supported
it is for me,
and
man.
cared for. Yes.
It is so huge.
Yeah.
I just see my partner showing up and I'm like, I love you.
Yes, it's
I love you so
amazing.
deeply. And then lastly, physical comfort. Is your body hurting? Is something causing pain during sex? You've got to address that.
Yes,
So
definitely.
those are really the 5 pillars of desire, and a great takeaway. We want to leave you with this, that you are not broken. Your body is not failing you. It's communicating with you.
Yeah.
We've got to listen to our bodies, to the science, to ourselves, and then we can begin to restore not just the desire, but connection, confidence, and wholeness. Thanks for listening. Please share this with a friend and subscribe so you don't miss the next episode.
Thank you for joining us on a journey to whole woman health. If this episode encouraged you, share it with a friend, leave a review, or subscribe so you don't miss future conversations. Remember, your questions matter, your health matters, and wholeness is a journey. Until next time.
Now for the legal language. The information shared in this podcast is for educational purposes only and is not intended as medical or mental health advice. Listening to this podcast does not establish a doctor-patient or therapist-client relationship. Always consult your own qualified healthcare provider regarding any medical concerns.